participants, I think last week when we talked about functional echo. Uh, Patent ductus arteriosus has remained an enigma for most of us, and still we're not able to answer many questions related to patent ductus arteriosus, including how do we assess the hemodynamic significance, as well as how do we manage patent ductus arteriosus. So, what I'm going to talk about today is the assessment of patent ductus arteriosus on functional echocardiography. So, basically, how a pediatrician or a neonatologist can assess a PDA. That's what I'm going to talk about. And in this presentation, we'll try to understand the havoc which is caused by a large PDA inside the heart, and it leaves a kind of signature in the various chambers and various blood flows and various measurements in the heart. So we'll try to see to assess how to assess if the duct is patent, what is the size of the duct, what is the direction and pattern of flow. So is it left to right, or is it really kind of a large duct which is pulsatile, what we call, or is it a small duct and restrictive? And we'll try to reach or at least have some kind of idea what is a hemodynamically significant duct on functional echocardiography. Well, so we all are at first clinicians before we pull the probe and talk about the various echocardiographic parameters. It's also important to understand what kind of clinical features a hemodynamically significant PDA can cause. And right now, the concept of causing a PDA as a hsPDA or a hemodynamically significant PDA is when both clinical as well as echocardiographic signs are present. So things have changed in the last decade, where hsPDA was only on functional echo, but now should have a combination of both the clinical features as well as the findings in functional echo to call any PDA as an hsPDA, so that you decided to treat or not. That again could be another question. So, when there is a significant PDA, there is a connection between the aorta and the pulmonary circulation. So, blood is flowing from left to right. So, there's blood flowing from the aorta to the pulmonary arteries. So, what happens is basically because of blood flowing in the pulmonary arteries, there is pulmonary overcirculation. So, you have a lot of blood flowing in the lungs are flooded. So, these patients can manifest as worsening respiratory distress. So maybe a preterm baby initially gave surfactant, improved, and day 4, day 5 starts to worsen again. So that could be a kind of presentation. So they could have reduced lung compliance, so increasing ventilation needs, sometimes oxygenation failures. Some patients can present with pulmonary hemorrhage, especially if there is LA overload or LV failure. Then a patient or a baby who is exposed to a large duct for a long time can develop chronic lung disease. So that's also been seen. So these are the aftermaths of a PDA because of pulmonary overcirculation. Then this blood goes into the lung, comes back into the left heart. And so you can have signs of left heart overload. So you can hear sometimes systolic or a continuous murmur if there's a PDA. The precordium becomes hyperdynamic. So you see the apex fit may be in two spaces, rib spaces, or even three rib spaces. So it's in hyperdynamic precordium. The pulse pressure becomes wide, so more than 25 millimeter of mercury, because the diastolic pressure comes down. The peripheral pulses are easily felt, especially the dorsalis pedis. There could be compensatory tachycardia because of left heart overload. Then there, as it advances, there could be left heart failure. So initially there is diastolic dysfunction followed by systolic dysfunction. So there could be systemic hypotension. And as the left heart fails, the blood is again directed towards the lung. There could be pulmonary venous hypertension as well. So you can look for these kind of signs as a clinician in the bedside to know whether the signs of hsPDA are there and whether it is significant based on these findings. Then, as we know that blood is shunted from the aorta to the ducts, so during diastole, there is a phase of systemic steal And this systemic steal can lead to decreased perfusion in the various body organs, including the brain, including the kidney, gut. So all this could lead to even periventricular hemorrhage or periventricular leukomalacia, necrotizing enterocolitis, renal dysfunction. So all these could be a presenting feature of a PD. So simply speaking, there could be a baby who is on ventilator, FiO2 requirement is going high, and there could be baby who is going into a phase of shock. There could be a baby who has feed intolerance, necrotizing enterocolitis, or oliguria. So hsPDA could have varied presentations. That is what I want to convey to. Now, if you look at the findings which we are going to find in functional echo is based totally on the pathophysiology. So if you just follow the blood volume which is being transmitted from the aorta to the various part of the circulation, you're going to get the same finding on functional echo. So basically, if I simplify this in a schematic way, so you have a PDA, which is a connection between the aorta and the pulmonary artery. Okay. So what you can measure on functional echo is the duct. So you can measure the duct size, and the size of the duct you can also measure in relation to left pulmonary artery. So whether the duct is more than half of the diameter of the left pulmonary artery, then again it's a significant duct. And you can also index the size of the duct to the weight. So basically, you're measuring the diameter of the duct and indexing it to the weight or the LP diameter to understand whether the duct is large or not. Then there is a direction of shunt when there is a hsPDA. So it will be left to right purely, or at least predominantly. And you can look for the direction of the shunt on functional echo by putting color. And you can also guess whether the duct is small or large by looking at the color of the duct. So a large duct will have a nice laminar flow with an orange kind of reddish kind of color. A duct which is constricting will be more speckled kind of color. A duct which is shunting right to left will be more like a bluish color. So color can give you an idea about the direction of flow, and it can also tell you whether it is a large duct or it is a restrictive duct. Then in the duct itself, you can measure the velocity. So when the duct is small, the velocity is high. So high velocity duct is more likely to be a closing duct, a restrictive duct. Whereas when the duct is large, the velocity is low. A low velocity duct is again more likely to be hemodynamically significant. So a large velocity duct is restrictive. A low velocity duct is more likely to be pulse duct. That means it is more likely to be hemodynamically significant. So on the basis of the velocities also, we can classify a duct into pulsatile, or restrictive. Then what is happening? This blood from the duct is flowing into the pulmonary circulation. So you're going to have certain findings of pulmonary overload. So what happens when this blood, it flows into the pulmonary circulation, it flows into the LPA and the MPA. So MPA means the main pulmonary artery, LPA means the left pulmonary artery. So you will see increase in the velocities, in the diastolic velocities in the MPA and the LPA. So normally blood will not flow in the main pulmonary artery or left pulmonary artery in diastole. It flows only in systole. So right ventricle is pumping, pulmonary valve is open, in systole blood flows. In diastole, the pulmonary valve is closed. So there should be no blood flow across these arteries in diastole. So when there is a PDA present, what happens? The blood also flows in diastole across the main pulmonary artery and left pulmonary artery. So there are features of pulmonary overcirculation. Then the same blood has to return to the left atrium via the pulmonary veins. So the pulmonary veins also can get dilated, or you can see that the velocities in pulmonary veins are also high. So that can also be measured on functional echo. Okay. So gradually then what happens? The blood is entering into the left atrium. So there will be volume overload here on the left side of the heart, and the LA starts to dilate. So when the LA starts to dilate, again, the duct could be hemodynamically significant. And we measure a parameter called LA aortic ratio. So we measure the dimension of LA, the maximum dimension, and we index it to the aorta. So aorta will not change, and the LA aortic ratio can tell us whether the duct is significant or not. Now, blood from LA flows to the left ventricle, so there will be some signs of LV overload also, and so the left ventricular dimensions will also increase. The left ventricular end diastolic diameter dimension will also increase. Now, there's a lot of blood in the LA, so what happens? The mitral valve, it has to open early because of increased blood here, and therefore the time for the left ventricle to relax. So what happens when there is isovolumetric relaxation? The aortic valve is closed, the mitral valve is closed, the LV relaxes. But in PDA, there is so much of blood pooled in here that the valve opens earlier, and therefore the time for left ventricle to relax decreases. So there will be decrease in the IVRT. Similarly, there are blood flows we can measure across the mitral valve called the E ratio. We'll discuss that. And now the blood flows across the LV here. So what happens is a lot of blood coming here, a lot of blood coming into the LA, then into the LV. So the LV output, the LV output increases. So it's more like a high output kind of cardiac failure, okay, because of left heart overload. And then what happens, sadly, despite having so much of LV output, because there is a duct which is here, so it steals the blood in diastole. So there is ductal steal. Okay, so the LV output is high, but because of ductal steal, the perfusion of the end organs are impaired. So there is systemic steal. So you can see for systemic steal, that is, you can see the absence of blood flowing in diastole or reversal of blood flowing in diastole in descending aorta or other arteries like MCA, ACA, celiac artery. All this could be investigated. And then because of left heart overload, what can happen? Initially, there is hyperdynamic circulation. So you will have increased EFs myocardial functions. You will have higher ejection fraction and fractional shortening. And gradually, as there is LV failure, there will be diastolic failure. And later phase, ultimately, the myocardial functions will come down. So these the changes that the duct is causing inside the lungs and heart, and all these changes could be measured by functional echo. And you can follow the same scheme, the systematic approach to know whether a PDA is present or not, and if it is hemodynamically significant. So you have to assess the duct, size, direction, velocity pattern, assess for signs of pulmonary overcirculation, so LV volume overload, LV pressure overload, and LV output, assess for systemic steal, and assess myocardial functions. That's it. That's how you follow the approach to diagnosing a hsPDA. So in functional echo, what we do to look for the PDA diameter, we make a ductal view. So in the ductal view is basically a modification of short axis view. So heart is lying like this. To go for short axis, your pointer should be towards the left shoulder, and you're somewhere you have to go up between the say around the second third space just below the clavicle, and from there you make a ductal view and tilt your probe slightly towards the leg. In that case, you'll make a ductal view. So here we're trying to make a ductal view, short axis view, but it's high up, and the pointer is towards the left shoulder, somewhere in the left intraclavicular region, somewhere in the second and third space. And basically, by this view, you're going to look at the duct which is joining the pulmonary artery and the aorta. Okay. So what we see? So you will see the cross section of the aorta. So you can see this is what we call a Mercedes-Benz sign, where you can see the aorta here. And you will see the main pulmonary artery coming from on top. The RPA in the classical short axis view will wrap around the aorta. The LPA comes straight, and there is a descending aorta. If a duct is present, you will see a third limb sometimes, which is called a tripod sign, and you will see a third vessel joining the descending aorta. So all you have to do is measure the diameter of this vessel Okay. And you have to measure the diameter at the smallest portion. Okay. Usually the smallest portion is the pulmonary end. Okay. Next thing, what you're supposed to understand is that you have to measure that in the 2D mode. Okay. In the 2D mode, not in the color, because color will spill. Okay. So the cutoff for an hsPDA, the smallest cutoff is that if it is more than 1.5 millimeter, then it could be a hemodynamically significant duct. You measure the diameter of the LPA also. So if the PDA by LPA ratio is more than 0.5, that is, the PDA is more than half the size of LPA, it could be a hemodynamically significant duct. And you can index it to the weight as well. If the diameter by weight is more than 1.4, then it's a large shunt. So these are some of the cutoffs in the diameter which people have used to define an hsPDA. So this is a video. See again, this is aorta. This is your MPA. Here you see the RPA wraps around the aorta. This is your LPA, and this is your nice duct here, large duct, which is joining the descending aorta. You can freeze the image and you measure the diameter at the smallest portion. One trick which I can give you is once you freeze the image, you can zoom it and then you can measure the diameter. It will decrease the error. So here, see, the diameter is being measured at the smallest portion of the duct in the 2D image. These are the various cutoffs which we discussed. Okay. So again, here you see same 2D images for the PDA. So you have the MPA, the RPA, the right pulmonary artery, the left pulmonary artery, and you have a duct here and the descending aorta, and you measure the smallest diameter. Usually it is at the pulmonary end. Okay. The next point is after you have measured the diameter and you have indexed to these various uh, like weight and the LPA, what you can do, you can just put color and try to understand what is the direction of flow and what are the flow characteristics. So if a duct is shunting purely left to right, it will be red in color. If a duct is shunting purely right to left, it will be blue in color like this. A duct which is large will have a nice laminar flow. Laminar means nice, smooth, single color like this, like a red color. So this is a large duct. A duct which is small will have an orangish kind of hue like this. And you see this is the speckling which is seen at the duct. So this is a small duct. Okay. So it is showing speckled color. This is a large duct. So it's showing a nice laminar flow. This is left to right shunt. This is right to left shunt. This is predominantly left to right shunt. There's some bluishness seen. So we have to further interpret that because there is bluishness because of right to left component also. So just by putting color, I can guess about the flow characteristic. Laminar, this one, means a large duct. Turbulent means speckled color, means a small duct. And it can tell me the direction, whether it is left to right or right to left, or this could be left to right with some bidirectional flow. So this is just by putting a color, the Doppler color mode. Now, if you put a Doppler mode, so what you do, you put a Doppler across the PDA. You have to integrate spectral Doppler. And you can do it, you can put a pulse wave Doppler here unless the velocity is very high. If the velocity is high, then we put continuous wave Doppler. By putting Doppler, you will get some traces across the Doppler line. So the trace which is above the Doppler line is the left to right component of the PDA. And if it is below the Doppler line, it is right to left component of the PDA because of positive and negative Doppler shift. Okay. So look at this Doppler. So here when the Doppler is put across the PDA, everything, the entire flow is down. So there's a negative Doppler shift. This is a purely right to left shunt. I will be very, very scared to even touch this kind of duct. Okay. Now look at this flow. Here you have some flow upwards and some flow below, some flow upwards and some flow below. So this is a duct which is bidirectional. Now to decide whether it is predominantly right to left, you have to measure the time for which it is left to right. That means this time from here to here, and you have to measure the time from here to here when it is right to left. If the right to left component is 30%, that means the time from here to here is approximately 30% or more of the total time. then this is predominantly a right to left shunt. Again, those ducts should never not be closed. Okay. Now, if this is less than 30%, then it could be bidirectional, but the left component is predominant. We also look at the velocities. Okay. Now, so we'll talk about it. So this one is a pure right to left shunt. This one is a pure left to right shunt. And this one could be a bidirectional shunt. So it tells you about the direction of the shunt. Now, in Doppler, we also measure the velocities of the duct. So you see, this is the flow across the duct. This is the systolic velocity. And somewhere here is the diastolic velocity. Systole and diastole. Systole and diastole. So when the velocity is high, then it is a small shunt. So roughly speaking, if the velocity is say more than 200 centimeters per second or 2 meters per second, it's a small kind of shunt. But if it is less than 1.5 meter per second, it's a large shunt. So you put a caliper here and the machine will give you the velocity, the peak velocity. And depending on the velocity, you see here the velocity is 355, I think, centimeters per second. So this could be again a high velocity. Okay. Next thing, what you do, you measure the diastolic velocity also. Okay. Systolic velocity and diastolic velocity. Now, this is V max, the systolic velocity, and this is V min, the diastolic velocity. Okay. So if the systolic velocity is twice of the diastolic velocity, like this, like here. So you see the systolic velocity is twice or more of the diastolic velocity, then we call the duct as pulsatile duct. Means it is a large duct, it's pulsatile, it's unlikely to close very soon. Okay. So again, I will repeat, if the systolic velocity is twice of the diastolic velocity, then we call it a pulsatile duct. Whereas if it is not twice, and if there is very little difference between the systolic and diastolic velocity, like here, you see, there is less difference between systolic and diastolic velocity. So this is a restrictive duct. So by looking at the Doppler flow, I know this is a restrictive duct. This is not going to cause much of a problem. I don't need to worry about this duct. Whereas if I find a duct like this, where you have a pulsatile kind of pattern, then I would like to further assess the duct for other parameters. Okay. So we have evaluated the duct diameter, duct flow, and duct Doppler, in which we saw that we can look at the duct diameter and what is the characteristics of flow, whether it is laminar, it is turbulent, what is the direction of flow, and we can assess whether it is a pulsatile duct or it is a restrictive duct. After you assess the duct, next is you move into the pulmonary arteries. So you look for signs of pulmonary overcirculation. Okay. So what you do basically to focus at the pulmonary artery, you have to form a parasternal long axis view. So your probe is placed somewhere at the junction of upper two-third and lower one-third here. And the pointer should be towards the right shoulder. This is the parasternal long axis view. So along the axis of the heart, so long axis, and in the parasternal area, therefore parasternal. And you drop your wrist so that you are basically sweeping your probe slight anteriorly by dropping your wrist. Okay. So when this is done in the parasternal long axis views, we have modified. So this is called modified parasternal long axis view. You will open up the pulmonary arteries. Okay. So this can be done. So you see here, this is the parasternal long axis view. And when you drop your wrist and with an anterior sweep, you will open up the pulmonary arteries like this. So this is the main pulmonary artery. And I want to look at the blood flow at the main pulmonary artery, or I can look at the blood flow at the left pulmonary artery. Okay. So what I do, I put color to see the blue flow, and I can put a pulse wave Doppler at the tip of the pulmonary valve. Okay. So when I put a pulse wave Doppler here, then I will get a Doppler trace. Okay. So I get to trace across the blood flowing across the pulmonary artery. And you see here, the color will be blue, and you will see the trace below the Doppler line, because what is happening, your blood flow is away from your probe. So whenever its blood flow is away from your probe, The color will be blue and you will see the trace below the Doppler line. So normally you see the flow you will see is a clear envelope in the pulmonary arteries. Okay. So in diastole, there is no flow. There is only flow in systole. So valve is open, blood is flowing, valve is closed, blood flow stops, then there is diastole, and this repeats. So this is normal flow across the MP. You get a nice clean envelope across the MP. Okay. Now, when there is flow in diastole because of a PDA, you see the envelope, it becomes fuzzy. So you're seeing flow across diastole. So this we call as turbulence. So there is turbulence in the MPA flow, or there could be a turbulence in the LPA flow. Okay. So the if there is a diastolic flow in the MPA, if you can measure this flow, the peak flow in diastole. So if the peak diastolic flow in the MPA is more than 0.2 meters per second or 20 centimeter per second, and in the LPA, if it is more than 50 centimeters per second or more than 0.5 meter per second, then it signifies this turbulence in the pulmonary circulation, and it could be because of a significant. So there are again cutoffs for mean velocity and end diastolic velocity of LP as well. And the specificity and sensitivity is close to 90% to diagnose an hsPD. So you will find signs of pulmonary overcirculation in the MP and the LP. Okay. Now, another sign of pulmonary overcirculation is this blood returns to the left atrium, and we measure something called the LA aortic ratio. This is a very common and important parameter to measure, and this is quoted in most of the literature, the LA aortic ratio. So what we have to measure, we have to measure the LA and the aorta. So you form the same plaques field which we just talked about. The pointer is towards the right shoulder, and you place the probe in the upper two-third and lower one-third of sternum. And once you place the probe like this, you will see the heart like this. So the posterior most chamber is the left atrium. Then you have the left ventricle. Then you have LVOT or the aorta. You have the septum and the right ventricle. So I want to measure the LA and the aortic both. So LA aortic ratio I want to measure. So for this, what I will do, I will drop an M mode Doppler at the aortic valve. So at the hinge of the aortic valve, I'll drop the M mode perpendicularly, and I will measure the dimension of the aorta in systole, and I'll measure the dimension of LA when it is at the maximum. Okay. So M mode at the hinge, perpendicular LA should be exposed. So you see here again, this is the video. Look at this LA. Visually also I know that the LA is large. Look at the aorta. The LA seems to me almost twice or more than that of the aorta. So this is a large left atrium, and here I assume the LA aortic ratio will be close to 2 or more. So once you drop an M mode at the hinge of the aortic valve with the LA exposed, you'll get a trace like this. So the posteriormost trace here is the trace for the left atrium. The middle trace here is the trace of the aorta, and above is the trace of the right ventricle. So I measure the LA at the maximum dimension. So here my B is the LA, which is 1.24 centimeters. I measure the aorta in systole. We can take from inner to inner. So this is 0.52. So you see here, if I calculate the LA aortic ratio, it is 1.24 divided by 0.52. It is more than 2, 2.2, something like that. So the LA is enlarged, okay, and it is indexed to aorta. That's what we do in the LA aortic ratio. Grossly speaking, a ratio, LA aortic ratio of more than 1.4 has been taken as significant, but I am worried when the ratio is close to 1.8 to 2. Then in the same view, if you move towards the ventricles instead of the aortic valve, if you cut the M mode towards the ventricles, then what happens? Here the chamber now becomes the left ventricle. And in systole, the left ventricle dimensions are small. In diastole, the dimensions will become big. In systole, it becomes small. In diastole, it becomes big. So you can measure this dimension, left ventricular and diastolic diameter. And this will be also increased because of left heart overload if there is an hsPD. So ideally, you should follow, there are Z scores and chart to be followed. Grossly speaking, in an infant who is less than 30 weeks, if it is more than 12 millimeter, then it could be a scenario of volume overload. Then for the pulmonary circulation, you can also look at the velocities at the level of pulmonary veins. So you put color at the pulmonary vein. So this is called a crab view, where your probe is placed transversely somewhere up below the clavicle, and you tilt it below with the posterior tilt, and you will be able to see the left atrium and the pulmonary veins entering into the left atrium. This is called the crab view. Now, to look at the blood flowing into the LA through this pulmonary veins, you have to make the color gain low. And if you put a Doppler here, you will see there's a triphasic flow. Okay, so there's a flow in systole, there's a flow in diastole, there's a reversal of flow. So what happens? The velocities, these velocities, especially the D wave velocity, will go high in the pulmonary veins. Okay. So again, it tells you that more blood is returning from the pulmonary veins into the LA. There's increased flow, and that could be a sign of hsPDA. Then the other signs of pulmonary overcirculation could be more blood flow coming into the left heart. And so the LV output increases. The LV output can go more than 300, 350 ml per kg per minute. And in the last class, when we discussed shock, the video is already on YouTube. You can see how we calculate the LV output in detail. Okay, so if you form an apical four-chamber view, and once you form an apical four-chamber view, you modify it to form the five-chamber. So this is your LA, this is LV, this is aorta, RA, and RV. So across the aorta, what you're going to do, you're going to place a pulse wave Doppler. You'll get a color, blue color. We'll put a Doppler trace here, gate here. You will see the aortic flow. Okay, again here, since it is away from the probe, you will see a blue flow. You trace this area. This is called the VTI, velocity time integral. And then the next job is to measure the diameter of the aorta. So for that, again, you go to the same modified Plaque's view, which we already discussed, and you can measure the diameter of the aorta in the M mode or in the 2D mode. So once you have the VTI and you have the diameter, then you can put this in the formula. So LV output is heart rate into VTI into pi d squared by 4 divided by the weight in kg. So normal LV output is somewhere between 150 to 300 ml per kg per minute. So if it is more than 300, 350 ml per kg per minute, that means the LV output is increased. And that is because of high output caused by the PDA. You can also index it to the SVC flow. So you can measure the SVC flow and index it to LV output by SVC flow. If the ratio is more than 4, that means the LV output is high. So these are signs of, again, pulmonary overcirculation causing increase in the LV output. Then there are a few parameters. There are a few parameters which you have to understand. One is the EA ratio. This is very easy to take out. So basically what happens from the LA to the LV, blood is flowing when the valves are open. So when there is LV diastole, the mitral valve opens and blood flows from the LA to the LV. Now it has two phases. First is the early phase, when blood flows passively from the atrium to the ventricles. And at the end, whatever blood is left, the atria contracts to push the blood. So this diastole has two phases, an early phase called the E wave, and again a phase of atrial contraction which occurs later on called the A phase. So normally what happens, more blood goes in the early phase than because of atrial contraction. So if you measure the E and the A wave, so normally in a term baby, the E by A ratio is more than 1. That means the E wave is taller than the A wave. In preterm babies, they have some inherent diastolic dysfunction. So blood is not able to flow passively very well because the ventricle is not relaxing. So majorly what happens, the blood is pushed after atrial contraction. So the EA ratio in a preterm baby will be less than 1, close to 0.8 or 0.7. So the E wave is smaller and A wave is larger. This is normal in a preterm baby. What happens in hsPDA, there is so much of blood which is in the LA that the E wave again increases and the E ratio reverses and E wave becomes large, something like this. So the E wave is larger than the A wave. So E by A ratio becomes more than 1, just like a term baby. This is called pseudo normalization of the E ratio. More is the E wave compared to the A wave, larger is the duct. So E ratio more than 1 in a preterm baby means pseudo normalization. could be because of significant duct. More than 1.5 further could be that the duct is much more large. Then we talked shortly about the IVRT. I gave you the concept. Now, IVRT is isovolumic relaxation time. So the time when the ventricle is relaxing, that is what we are trying to capture when both the valves are closed. So here we are capturing both the aortic and the mitral flow. So what is happening basically here? Here the diastole has started. The mitral valve is open. Blood is flowing from the left atrium to the left ventricle. And here the blood flow stops. Now the mitral valve is closed. The aortic valve is also closed. And what happens now in this phase? Again, this will be a phase when the aortic valve is still closed. The LV then contracts and blood flows across the aortic. So this happens in systole. So after the systole is over now, the aortic valve is closed. The mitral valve is still closed. And there's no blood flow inside the LV. The LV is relaxing. This is a phase of isovolumic relaxation. And then the mitral valve again opens up and blood flows from the LA to the LV in diastole. So this phase, when the aortic valve is closed, the LV is relaxing until when no blood is flowing, that is the mitral valve is also closed. Both valves are closed and LV is relaxing is called isovolumic relaxation time. So normally it is more than 55, 60 milliseconds. So what happens when there is a lot of blood here in the left atrium? So the mitral valve has to open early. It doesn't have that much time. So mitral valve opens early and the LV doesn't have enough time to relax. So the IVRT, this time will decrease. Shorter is the IVRT, more significant is the duct. So there are cutoff values again, less than 35 and so on, which you can remember if you want to, which tells you that there is shortened IVRT and which could be because of an hsPDA. Then there could be some features of systemic steel. So in an PDA, if you put color across the major vessels, so you can interrogate the descending artery. So normally we expected to have a flow in Doppler, in systole, and in diastole. In systole and in diastole. When there's an hsPDA, what happens? There is a steal of blood flow during diastole. So the diastolic flow could be absent, something like this. There is no flow in the diastole. Or if there's a larger duct, there could be reversal of flow in diastole, something like this. Okay. So these are the flow patterns of systemic steel. This can be seen in the descending aorta, or you can also see this in other vessels. Like you can see this in the SMA, in the superior mesenteric artery. You can see in the celiac artery. You can see in the renal artery. You can see in the brain. So if you get a duct flow which is reversal or absent, then it could be a significant duct. And lastly, you can assess the cardiac function. This we already discussed in the last class, how to look at the cardiac functions. And you can see the fractional shortening, that is how the LV is contracting, or what is happening to the LV dimension in systole and in diastole. And you look at the change in the dimensions. So left ventricular and diastolic diameter minus left ventricular and systolic diameter divided by left ventricular and diastolic diameter is called the fractional shortening. Basically, the change in diastole and in systole, which you're measuring. So normally it is around about 30%. If it is less than 23%, the FS is low. If the FS is very high, which can happen in high output failures, so initially you will have a high fractional shortening. Later, when the LV is compromised, the FS can come down. And you can also measure something called the ejection fraction. This also I have given you the concept last time. I don't have so much time to cover this in detail, but you can also measure the ejection fraction to understand what is the myocardial contractility in the left side, what is happening. Okay. Or you can also do tissue Dopplers and so many things. So summing up the parameters, you can look at the ductal characteristics. So you can see the diameter and the cutoffs I told you, the smallest cutoff is 1.5. You can look at the PDA-LPA ratio. The cutoff is 0.5. That means the PDA is at least larger than half of LPA. And the diameter by weight could be indexed if it is more than 1.4. Again, it could be a large shunt. So basis on diameter, the caution is measured in 2D. Measure the smallest diameter and measure, you can zoom the image and then measure the diameter. That would be more accurate. Look at the flow, laminar, turbulent. I told you how to differentiate, and you can understand the direction by putting the color also, or by putting Doppler, whether it is left to right or it is right to left, or it is bidirectional. All this information could be obtained. Then, and the duct, you can put pulse wave Doppler if the velocity is not very high, or you can put continuous wave Doppler, measure the systolic and the diastolic velocity. So if the diastolic velocity is half of systolic, then it's a pulsatile duct. If there is less difference between the diastolic and the systolic velocity, then it's a restrictive duct. Restricted ones more likely to close, pulsatile ones may cause problems. Similarly, if it's a high velocity duct, if a peak velocity is more than 2 meters per second, then it's a small shunt. I won't be much worried. But if it's a low velocity duct, less than 100 centimeters or 150 centimeters per second, then it's a large shunt. Again, it could be hsPDA. For pulmonary circulation, we discuss about how to look for certain signs like the increased LV output or the LV output SVC ratio. Signs of volume overload, we discuss about the turbulence in the main pulmonary artery, left pulmonary artery, the diastolic velocities will increase. The left ventricular and diastolic diameter might increase. You will see increased flow in the pulmonary veins. You will see enlargement of the left atrium, so the LA aortic ratio will go up. For the LV pressure overload, I discussed very briefly about the EA ratio and the IVRT because time is limited for me. And we discussed how the EA ratio, there is something called pseudo normalization when there's a large duct in a PDA. EA ratio becomes more than 1. The LV may get lesser time to relax because there's blood sitting on top and the mitral valve opens up early. So the IVRT, isovolumic reaction time, decreases. And then you can see features of systemic steel. You can assess the myocardial functions in a tummy. So you can go in this sequential manner, then you will not miss the parameters and it will be easy for you to understand the hemodynamics. Now, these again are the various cutoffs which are published regarding a small shunt, moderate shunt, and large shunt. So these are some values if you want to know. I mean, you can just remember them. The same, you understand the concept, the values you can always see from any standard chart, any article. Same concepts are being given here. I was told to touch upon the staging of the PDA, and this is one of the old articles 10 years back, but still relevant in today's world, where a PDA could be staged clinically. So its clinical staging is there C1, C2, C3, C4, and it could be staged on echocardiography as well. So here you see C2, C1 is asymptomatic both. C2 clinically basically is when your oxygenation is increasing, you need some respiratory support, there's feed intolerance and so on. C3 is when the ventilator needs are high. So you go up to a map of 9 to 12. There is hypotension, requirement for inotrope. There is some metabolic acidosis. C3 is the worst case, severe when the OI is more than 15. There is high map. There could be hemodynamic instability requiring more than at least 2 or more inotropes. Severe acidosis is again C3. Then again, in terms of echocardiography, the same parameters which we have discussed. So these parameters are like little, let's say, looser in the milder variant. So when the duct diameter, the duct is there, but it's less than 1.5. Restricted flow, high velocity duct, LA aortic ratio less than 1.5, no signs of volume overload, no signs of pressure overload. This is a milder variant of duct. But when the duct is 1.5 to 3, there's a large duct. It's a moderate variant. You have pulsatile flow, some volume overloading, so LA aortic ratio between 1.5 to 2, some pressure overloading, EA ratio more than 1, but less than 1.5. It's a moderate kind of duct. The severe is again more than 3, pulsatile transductive flow, low velocity duct, LA aortic ratio more than 2, EA ratio more than 1.5, IVRT less than 35 milliseconds again could be a severe kind of hsPDA. So there are staging system, and this is still relevant in today's era when we are talking about which duct to close and which duct to leave in a conservative manner. Then there is one scoring system given by Al Kufas. It is not easily memorized and difficult in practice, but for the sake of discussing it, I'll give you. So this is a regression equation, which is gestation age in weeks into 1.3, PDA diameter into 0.7, LV output into 0.08 plus PDA velocity into minus 1.065 plus LA, A wave in centimeter, and so on. So if you put the parameters here, then you get a score and a value. So total out of 13, if it is more than 5, then this duct is more likely to be HS significant PDA, and it can predict the bad outcome of chronic lung disease or death with a sensitivity of 92% and specificity of 87%. Then This is another scoring system again, who looked into the LVO SVC flow, and look what happens when this LVO SVC flow is ratio is more than 4. So you see when the aortic ratio is close to 1.4, 1.5, which is here. Ductal diameter in B mode close to 2.53. Again, ductal diameter in color, if you see, then somewhere around say 2.53. Velocity in the LPA. So if the velocity is somewhere around zero point 0.5 meter per second, and the acyclic velocity in the LPA, when this is around 0.2. So LVO SVC has been taken as a marker, and these various kind of parameters have been assessed. So this is another scoring system which is there. Okay. So that's it what we discussed today. We discussed today on echocardiography to understand if the duct is patent or not, and we measure the size of the duct and index it to various other parameters like the LP and the weight. We interrogated the duct on Doppler and color views to understand the direction, the pattern of flow, and then we discuss various parameters to ultimately reach a kind of understanding whether the duct is hemodynamically significant on echocardiography or not. And various parameters we discuss, including some parameters of pulmonary overcirculations, like the MPA diastolic velocity and the LPA velocities and the pulmonary venous velocities, LA-aortic ratio, then some pressure overload parameters like EA ratio, IVRT, some parameters of volume overload, LV output, and so on to understand the significance of the data. So that's it from my side, and thank you so much. I had to rush through in between because I didn't want to exceed much time. We're already running late. Any questions, I can take it.
Thank you so much, Dr. Anup.
Yeah.
Are there any questions? I see a lot of questions on slides, but I was able to see the slides moving for most of the presentation. I'm not sure whether some of them were not able to see the slides. Does anyone have a quick question for Dr. Anup? You can type your questions and I can read it out. So can you explain how to calculate LVO, sir? Left ventricular output.
Okay, so basically for left ventricle output, I will try to explain the concept to you. You can think that LV is a cylinder, okay? And you know the formula for the volume of a cylinder, it is pi r square h. Okay, that's what we learned in our class 6th or 7th, right? Pi r square h. So if you assume an LV as cylinder, I need the radius. So instead of that, I have calculated the diameter of the aorta, and I need this h, so height of the cylinder. So instead of height, what we calculate is a VTI. VTI is velocity time integral, which is the movement of RVC in one stroke, same as the height of cylinder. So you have the VTI, you have the diameter, you put it in the formula, so which is pi d square by 4 into your VTI into your aortic diameter. So that is your stroke volume. Okay, stroke volume. If you multiply into heart rate, that gives you the cardiac output. And if you divide it by the weight, it gives you the cardiac output per kg per minute. So we need two parameters. One is VTI, and the other one is basically the diameter of the aorta. So what we do for the VTI, we make a 5-chamber view. So you first make a 4-chamber view, and there's an anterior tilt to expose the aorta. You put a Doppler, and you will get, I'll show you the slide. So you will get a trace below the Doppler line. Yeah, so this is here. This is your LA, this is LV, this is aorta. So you open up the aorta by forming a 5-chamber view. And then I put a Doppler here. I get a trace like this. Okay, this is the blood flowing across the aorta. And if I trace this area, it gives me the VTI, the velocity time integral. Okay. So it's around say 17.7 centimeters. And I have to take the diameter of the aorta. For diameter, I made the modified flax view, and I can measure the diameter in the M mode or in the 2D mode. So if I put them in the formula, the VTI 17.7, the diameter here, for example, it's 0.5. The value of pi, you all know, it's 22/7. And the diameter heart rate you can take from the monitor or you can take from the echo machine. If you put this in the formula and divide it by the weight of the baby, you will get the cardiac output per kg per minute. So that's how we calculate the LVR. Okay. So there are some other questions. So one,
When to treat a symptomatic PDA? I think Dr. Anu wanted to avoid that question specifically, but would you like to quickly answer that question, Dr. Anu?
yeah. So when to treat a asymptomatic PDA, you don't need to treat asymptomatic PDA at all. So that is again out of questions. Right now, the debate is whether we should be treating symptomatic PDA or not, and which ones to treat. So, if you look at the last few years, there have been large RCTs published, Oscar trial, Benedictus trial, PDA tolerate trial, which have seen that whether you treat a significant PDA or not, it doesn't cause any difference in terms of outcomes, such as chronic lung disease, mortality, NEC, there's no difference. So people are debating whether we really need to treat PDAs pharmacologically. But again, there will be some section of babies which you will need to treat, perhaps. That could be extremes of gestation, like less than 26 weeks, a large PDA, causing features of pulmonary overcirculations, like the child being on ventilator with high FiO2, or there could be signs of like shock. So those kind of PDA probably people would be treating still. So asymptomatic PDA, don't worry.
Okay. Thank you, Dr. Anup. I think we have answered most of the questions, and probably you can take up that last one on steel phenomenon, if possible, by a message, because we are already at almost 9:40, and I might
Okay.
probably request Dr. Sriram to begin with the last slide.
Okay. So steel is what basically, see, when there is systole, the blood is being pumped from the LV and blood goes into the aorta. Okay. So what happens in diastole as the pressures come low? So there is flow of blood from the descending aorta towards the PD. So what is happening in diastole? The blood is expected to flow forward towards into the descending aorta and then into the body to maintain the perfusion. But if there's a large PDA here in diastole, what happens? The blood flows across the duct. So this is called diastolic steal. Okay, systemic steal. So there's a steal in diastole, and it's called systemic steal because it is stealing blood from the systemic circulation. It is stealing blood from the aorta, and therefore the perfusion of the other organs would be compromised. So this is seen, this blood flow, you can see in the Doppler traces. So normally blood is supposed to flow forward. So you should see a trace of Doppler in diastole and in systole, both should be positive. So there should be systolic flow and there should be diastolic flow. But when there is a steal phenomenon, what happens? So I got this for you. Yeah. So this is a flow in systole. This is a flow in diastole. So when there is steal happening because of a PDA, then what happens? The diastolic flow could be absent or it could get reversed. So you see here, the systolic flow, there is no diastolic flow. Or it could be a scenario like this, where there's a systolic flow forward and there's reversal of diastolic flow. This is worse than this one. So this tells you there is systemic steal, or there's reversal of diastolic flow, or reversal of flow in the aorta in diastole, whatever way you want to call it. And this is one of the markers of systemic steal, and a very important marker to define a PDA being an hsPDA.
Yeah. Thank you, Dr. Anu. We'll, I think, move on to the next talk, which is going to be by Dr. Sriram. Dr. Sriram is neonatologist who is currently at Ankura Hospital, Hyderabad, and he has completed his DM from AIMS, and he's a great clinician and an excellent teacher. So we'll request Dr. Sriram to address us on newborn screening approach to abnormal thyroid screening. Over to you, sir.